settle in for the evening with us for a riveting show on all things GLP-1s, PCOS, and what does the future hold. Okay, great. Got lots of people joining, which I am very grateful for. You giving us your evening as we give you ours. So I'll get started because we've actually got quite a lot to cover in the next hour. It gives me great pleasure, the greatest pleasure actually, to bring you this webinar with Dr. Paul Hardiman, who is an incredible consultant. We had the pleasure of working together many moons ago. Dr. Hardiman actually was the supervisor for Dr. Natalie, our COO and co-founder. So it's where we first met each other, was actually dissecting bovine ovaries. Like I always say, there is nothing that'll bring you closer to somebody than cutting up a cow's ovaries to learn more about how vascularization. So Dr. Hardiman is an associate professor at the Institute for Women's Health. He's director of the Ovarian Tissue Cryopreservation Service and honorary consultant in obstetrics and gynecology at the Royal Free Hospital in London. Honorary consultant in the fertility clinic at the Whittington Hospital and joint founder of the UK Oncofertility Consortium and the Interdisciplinary Centre for Reproductive and Experimental Cryobiology. He trained in obstetrics and gynecology in Newcastle and at St Bartholomew's Hospital, London, and his initial research was in the vascular effects of menopausal therapies under the supervision of Jean Ginsberg at the Royal Free Hospital School of Medicine, and spent 1 year as a postdoctoral fellow at the University of Sydney, Royal North Shore Hospital, Australia, and Toronto University Mount Sinai Hospital. So, Dr. Hardiman, we have a great night in store, and it's been many years since we actually spoke. And I think it's probably when we were supervising students together in UCL. But I'm delighted to be able to share all your expertise. The first, people may not know this, but the very first versions of Hertility were all really built with Dr. Hardiman's input at every stage. We would call him up for all of his insights and help in building our health assessment. So how we're going to format the evening is we're just going to share some slides with all of you so that everyone is on the same page. Sometimes we can use terminology, sometimes we can use phrases, and we assume that everybody knows them, but we're going to go back to some basics, bearing in mind that all of you are experts in PCOS. When you have the condition, you are an expert in the condition, but we're just going to run through some of the main aspects of it. So let me just find my slides. I think I have this open twice. Okay, where are we? I'm going to go back to the start here. Present. Okay, can we see just this?
Yeah. Good for me, Helen.
Great. All right. Perfect. So we'll make a start. I introduced Dr. Hardiman, but my name is Dr. Helen O'Neill. And for those of you who don't know me, I'm the founder and CEO of Hertility, but I'm also an associate professor in reproductive and molecular genetics at the Institute for Women's Health in UCL. I am going to give you a little bit of an introduction to who we are at Hertility. And then we're going to go through why we're here, because we're here to educate you, and then why you're here to learn about PCOS and GLP-1s. But first, just to give you an idea of where we're at, why Hertility exists, and what Hertility is today. So Hertility is essentially a diagnostic test that screens for over 18 different gynecological conditions. We have built the largest data set in the world of female gynecological pathologies, and it starts with an online health assessment. So this online health assessment that you will complete is really critical to us getting a full picture of your reproductive health. Sometimes when we talk about fertility, we isolate it, or some clinics will only measure AMH, but really your fertility it needs thorough investigation into your menstrual cycles, your overall reproductive health, your symptoms, your biometrics, sometimes your lifestyle conditions. So this health assessment helps us to determine what your relative risk is of any one of 18 different gynecological conditions. Now, you may not have any condition, many people have hormones that are clinically out of range. Over 60% of people who test with us have at least one hormone that is clinically out of range, which is probably not surprising given our lifestyles, our stress, our exposures. But nonetheless, that health assessment is really critical to the journey, and we've spent 6 years developing it and developing the predictive outcomes that we get from it. But most importantly, we use that health assessment to determine what's the most appropriate panel of hormones. So we test up to 10 hormones. We will always test your thyroid hormones. We will always test your cycling hormones, unless you're on hormonal contraception. We'll always test your ovarian reserve marker, or your egg reserve, or AMH. But if you trigger something like PCOS, we'll also test your androgens, so that we can, if you have a suspected diagnosis, or indeed if you tell us you have PCOS, we'll be able to confirm that diagnosis through the blood results. So we confirm that blood result by sending you a kit that you can do a blood test from home. Importantly, it's critical that you measure your blood on the day 3 of your menstrual cycle. So having a kit at home enables you to actually get access to doing a blood test, irrespective of whether you're working or whether it's a Sunday. And so it removes some of the barriers to entry in our busy lives of having to physically go to a clinic and give blood on the 3rd day of our periods, which is, we only have 12 of those a year, or fewer if you are anovulatory. And then the next really critical part about that journey is that we have created a really robust doctor-written report. This isn't just results that are given to you like your FSH is 12 picomoles per milliliter and a reference range of 8 to 100, and you're frantically looking to see, if I'm out of range, what does this mean for me? What we've taken is every single hormone that we test, we explain what it is, why did we test it, and what it means for you. And then you're given a full care plan and full interpretation of your blood results. So we've coded over 54,000 clinical scenarios. So each report is unique to you and tailored to you. And we're really working towards making sure that everyone sees that everything that you've told us in that health assessment in step 1 is then embedded within that report. So we're not just giving blood results, but actually putting your blood results in the context, the clinical context of your lifestyle factors, menstrual factors, and any of your symptoms. So it's really important that we get this full picture. So that's why we encourage everyone to download the app, so that we can actually go beyond that static health assessment and have continuous tracking of anything that changes, so that should you start to log anything and it gives us insights into, maybe this is something that you only ever get. Maybe you only get migraines when you are ovulating, or maybe you only get them in your luteal phase. It enables you to track clinically relevant metrics, but also associate different times of your menstrual cycle with particular symptoms. So we never leave anyone without any onward clinical care, and we've worked very hard to ensure that we have a full suite of clinical services, whether it's an ultrasound scan that you need, or whether it's a prescription, or whether it's speaking to a gynaecologist, or just getting advice from a fertility specialist, or whether it's that you want egg freezing or IVF. We have the full, or HRT, we have the full spectrum of clinical services, all under one Hertility roof. Okay. So I thought it was important to just highlight what it is that we do. So should you need a blood test, we're here for you. Should you need an ultrasound scan, we're also here for you. But if you want to talk through your results and get a prescription, that can all be done here at Hertility. And actually, our prescription service is stunning. You can speak to the doctor that day, and it can be ordered to your nearest pharmacy that day, or have it posted to your house the following day. So it's really quite streamlined, actually. So we shall move on, and I'm going to let Dr. Hardiman take the floor to run through some of the definitions, symptoms, diagnosis, and management. And we're going to make it as conversational as possible. So Dr. Hardiman is the expert. So should I have any questions, I will naturally weave them in, and then we'll get to some questions also at the end. So Dr. Hardiman, I will control the sides, but you can take the floor.
Okay, so it's nice of everyone to tune in to me, and I hope you find this of interest. One of the things you'll notice is that I'm not 21 anymore. So I started working on PCOS in 1986, before almost everyone in the audience was born. And what I say to my patients is, even if I wasn't clever, just all those years of experience should give me some wisdom. I've seen most things in the last, how many years is that? That's 16 years, that's 41 years of treating PCOS. So I think I've learned a few things about it. One of the things that I've learned about it, actually, and I digress a bit, but it's worth saying, is that this affects, and you the audience will know this affects you as a person much more than many other members of the public or even doctors or even gynecologists understand. So the symptoms of it are variable, and we're going to talk about them. But the effect on your quality of life, what it feels like to be living day by day, is profoundly affected by this. And I don't think the NHS takes that into account. I mean, the NHS is now famously bankrupt, but even when it wasn't, there tended to be a lack of funding for PCOS. I think in those days, all those years ago, mainly because the people who were running the NHS were old men who actually were losing hair from the top of their head, and for them, hirsutism or excess hair growth would have been a good thing. So I think it was a question that the NHS didn't understand it, and it still doesn't really understand it enough, because I know how you people out there will be suffering from this thing. I'm just going to enlarge my screen a bit because I'm looking at it on my phone. So there have been, in the years that I've been doing this, there have been so many different definitions of the condition that you've got. Now, one of the reasons for that is that there's not something which we call a gold standard. Now, a gold standard exists for many conditions in medicine. So particularly if you've got something like cancer, you take a biopsy, you look it under a microscope, and you have or you haven't got cancer, and there's no argument to it. The problem with PCOS is there is no gold standard test. So we tend to use a combination of often of symptoms and of scan findings and blood tests to make a diagnosis. But probably PCOS is more than one condition. So one person's PCOS isn't the same as another's, and maybe that's why people don't fit into the categories. But the conventional definition that's used in the UK is what's called the Rotterdam Consensus Criteria. And I know you won't want to hear all these boring things, but historically, the Americans used blood tests as a means of diagnosing PCOS. We're going back 30 years now. And the Europeans used ultrasound because we had it more available. And so there were two different diagnostic setups or definitions. And the way that it was solved is a load of people went to a nice hotel in Rotterdam, sat down and said, well, you people in America think it's a blood test, and we in Europe think it's a scan. So the clever solution they came up with is that you can have PCOS either with a blood test or with a scan. So everybody was happy. So the Rotterdam Consensus Criteria are that you need 2 out of 3 things. So for those of you, because there's often uncertainty about diagnosis. I meet women who say, well, somebody told me I had PCOS and somebody else told me I didn't. And the definition that we use is you need to have at least 2 out of 3 things. And the 3 things are on the screen. One is that you have little cysts on the ovaries. Now, cysts freak people out because cysts can be all sorts of things, including cancer. These cysts are not cancer, have nothing to do with cancer. What they are, as you probably know, is each month when a woman ovulates, she produces a cyst in the ovary, which gets bigger and bigger, and then it pops to release the egg. And these cysts that we see on the scan are not pathological, so they're not abnormal. They're the normal cysts that are part of the ovulation process. But there's a dysregulation, there's a lack of coordination of the maturing of these follicles, so that many follicles are half cooked at the same time. So you needn't be worried when you hear you've got a cyst and you might hear that some relative had ovarian cancer or something. This is a different thing. They're just ovulatory cysts, partially grown. So one of the things is little cysts on the ovary, and these are in no order. Number 2 is irregular periods, or what they call oligo-ovulation. Oligo is Greek for not very often. So it means not ovulating very often, which is manifest as not many people. Helen, I can't see myself on the screen. Am I roughly in the middle of the screen?
Yes, you are. Yeah.
Okay. God help you. So you've got irregular periods, we've got little cysts, and the third thing is hyperandrogenism. Now, you know that androgens are male hormones. Well, women have androgens as well. You shouldn't be freaked out if the doctor measures your testosterone, because you also have it, just less than men have it. And one of the criteria of diagnosing PCOS is a raised level of testosterone or what we call clinical hyperandrogenism, which means symptoms of it, which really means persistent acne or excessive hair growth on the face or body. So that's clinical because we can see it and diagnose it. So to have PCOS, you need to have 2 out of those 3 things, or all 3. And really, people with PCOS break down mainly into 2 categories. Those that have the irregular periods and not ovulating very often. And the others are those with androgenic symptoms. So they have excess hair growth and they have acne. The other thing worth saying, as I mentioned to you, you only need 2 out of the 3 to have PCOS. So if you're a person with irregular periods and let's say acne, even if your scan is normal, by this definition, you have polycystic ovary syndrome. So you can have polycystic ovary syndrome with a normal scan. And that's the thing which people find puzzling and surprising. Okay, should we go to the next? Can we go to the next? Okay, let's go to symptoms. Right. So the symptoms, as I say, mainly fall in the textbooks according to androgen excess, which means acne or excess hair growth, or scalp hair loss, or irregular ovulation. Now, Helen showed me this thing today, and it's fascinating. So, as she mentioned to you, they've got all these health questionnaires on huge numbers of women, including many, many, many with PCOS. And at Hertility, the symptoms of androgen excess, of testosterone excess, are the leading symptoms in their experience. So as you can see, excessive hair or acne are 1 and 3. Also mixed in there, and I'll come on to these, are psychological symptoms like anxiety and low mood. But irregular periods doesn't feature in that. Now, I was surprised by that, and I don't know why it might be. It might be because this, in a way, Hertility have got all these samples, which is an invaluable resource, and they've helped lots of people. But it's not a population study. So it may be the people that contact Hertility are more likely to be the people with those symptoms, and maybe people with irregular periods maybe contact them less. I don't know. But that's quite a surprising finding. It is what Hertility found. So of the people with PCOS who have consulted Hertility, they are what they have.
So where I think this might be, so the reason I wanted to pull this data was because when we did a study asking women how they got their diagnosis of PCOS, what took them so long to get their diagnosis,
Yep.
and what were the things that they found were lacking from the consultations that they had. What we saw from that study was that people were given advice about their weight. They were given advice about, they were asked if they were planning on getting pregnant. If they weren't planning on getting pregnant, they were told, well, think about it when you are. And many of them, actually a majority of them, presented with mental health, anxiety, low mood, depression, irritability, and not anywhere, either in the guidelines, does it mention mental health, nor in clinical consultations is mental health addressed. So that's where we really wanted to pull data from the actual top symptoms. But I will say this, of this top symptoms, I don't think it's that irregular cycles haven't mentioned. It's that we ask a separate question about your menstrual cycles. So that data I should have included here. I'm sure it's the same, but the symptoms list will have been listed separately to this. So that's probably my fault. I should have included that. But it is interesting
the first thing
that
you
the
said,
top 10, of the top 10, we see depressive low mood, irritability, migraines, brain fog, anxiety. Like 5 of the 10 are to do with your brain, your mental health, your mood, and yet nowhere in the guidelines does it say that those are the symptoms of PCOS, nor in any of the treatments is that included. So that's, for me, what really needs to be looked at. We published a report last year, and one of the pillars of I think it's above my head if you can see it here, the reproductive report. We do them every year, but one of the pillars of that was that mental health and menstrual health are inextricably linked, and yet we don't view them as such.
Helen, that's really interesting. There was something you said there, which I think is really important. And that is that the people that are coming to see you are often the people who've gone to their GP with what turns out to be PCOS, and they're coming to you with the symptoms that have not been addressed by the NHS or their doctor. Is that right?
Yeah.
Okay. And I'll tell you why that is. and you probably know why it is. It's because fixing irregular periods is one of the is in many ways one of the easiest things to do with PCOS. The symptoms you've got here are difficult to treat, and gynecologists don't know much about them. I'll let you into a secret. Medical students don't get very much training on mental health, and amazingly, very little training actually on the practical management of obesity.
Yeah.
So these are the symptoms that are left because their previous doctor hasn't treated them, and they haven't treated them because they're not quite sure what to do. And in some cases, we don't have very effective treatments. And we can come on to that in particular because I've got some views on that. I mean, that's entirely understandable now that the doctor can feel it used to be, and it's still a bit like this, that if you have PCOS and you have irregular periods, as you start saying that, the doctor's reaching for his computer or her computer and prescribing the pill for you because that'll give you regular periods. My mum's passed away now, but if she was still here, she'd be 95. If I gave her the pill, she'd have periods, right? So giving somebody the pill will give somebody regular periods. So these are the easy things to fix. The 10 you've got there are the more difficult ones. And the other thing that I would say is that this highlights two things. There's two things that matter a lot to me. One is that it applies to everything, but the treatment of PCOS has to be holistic. In other words, people don't just want to bleed every month on the first of the month. There are these other symptoms which they want to get better from. And you can't just give people a tablet, give them periods to say goodbye. So you have to tackle these other things. You're right, Helen, they're not part of the diagnostic criteria for PCOS, but all of the studies, including my own, show the symptoms you've got there are much more common in people with PCOS than people without PCOS. So a long time ago, I had a research fellow working with me who was a PhD, who was a psychologist. And he had done his PhD looking at the psychological symptoms in women with PCOS. And unquestionably, anxiety and depression were more common in people with PCOS. He had a control group, which is women who had blocked tubes. So they had infertility, but not because of their hormones. And the PCOS group overwhelmingly had more anxiety and depression.
Here,
but interestingly, it didn't correlate with their testosterone. So it is not the testosterone, as far as we can tell, that's making people with PCOS depressed. The correlation in his work, and in my clinical experience, I would still agree with it, is that some of the symptoms of PCOS are, well, they're obviously, I don't want to make people feel even more unhappy they are, but they're not symptoms that you'd want to have. Unfortunately, women are bombarded with images of female perfection, which rarely includes facial hair. So women don't feel good about facial hair. And I'm not saying, and in a way, it's a shame they're made to feel that way because it isn't painful, but they feel less feminine. They feel, in some cases, and I hope this doesn't apply to anyone in the audience, but in many patients it does, they feel less attractive. My clinic used to be full of women wearing scarves around their necks, concealing hair around their chin. And women, and the depression comes from not feeling good about yourself.
Mm-hmm.
I can remember one patient from 20 years ago, and she said to me that whenever she was single, but she wanted to have children. And it went something like this. She would meet a man in a bar or wherever she might meet him. They'd exchanged their names, and within 2 minutes, she'd said to him, I need to explain to you I've got polycystic ovary syndrome. I might never be able to have your babies. Do you want to walk away now? And how sad that was that she felt so burdened by this disease. And of course, men would have found it, off-putting. So the mental health problems come partly from low self-esteem, because all of the things that you might get are things that sadly that society would sometimes finds a problem with. So being overweight, being hairy, having acne. So that's where many of the trick to improving psychological symptoms in women with PCOS is very largely about getting their symptoms better, and then they feel better about themselves.
Yeah, it's very, it's very difficult to pull apart the psychological, the mental health, the distress, but also the anxiety. And also when that's shrouded with a lack of diagnosis, a lack of clarity, a lack of treatments, that really compounds the issue, because where is the end? And I feel like when one of the reasons when we asked what stopped you, what prevented you from getting a diagnosis, many people self-eliminate from treatment. So they will say, well, I just it wasn't bad enough for me to seek help, or I didn't feel it warranted a thorough investigation. And when that's one of the contributing reasons, and access to information, treatment and support or clinical guidance is not really available, then you're not motivated enough to actually overcome that and really seek out as much help as possible. So people just get put off and they self-eliminate from help often. Other people try their absolute best to get help, and unfortunately you're just sent away and told to lose weight. So there's a lot that needs to be done, which is why we wanted to host this webinar, really just to run through some of the treatment options that are currently available, as well as what is we think on the horizon. So let's talk about those treatment options and some of the management.
I'll take up my hand. So the as I said, by far and away the most commonly used treatment then and probably now in a woman with irregular periods and PCOS is to be given the pill. Now, that will give a woman regular periods. Obviously, it's inappropriate if she's trying to get pregnant, but it will give her regular periods, and some people find that helpful. One of the things I want to just kind of explain, which is a bit kind of nerdy, but it's worth knowing, and that is in your blood you will have some testosterone. Now, the level in women is up to about 1.7, and the level in men is from 12 to 30. So it's there, but in a lower level. Now, with PCOS, you might have a bit more, but only a little bit more. So not in the male range. We're talking about 2.5, maybe 3. So there's a mild elevation, not in all women with PCOS, but there can be that. Now, the nerdy bit is that there's a protein in your blood called sex hormone binding globulin. And the way I describe that to people is it's like a sponge and it soaks up testosterone. So that if you have testosterone in your blood, which you will have, the more of this SHBG that you have, the less the testosterone will act upon your skin, making it oily, giving you acne and making hairs grow. So for women, SHBG is your friend. And the double whammy in PCOS is not only is the testosterone slightly raised, but the SHBG is low. So what testosterone you have is working more. And it gets even worse because SHBG, this protein that's made by the liver, you make less of it, including men. We make less of it when we're overweight, which is where we're going to get onto this, which is where weight interacts with PCOS, because it's a genetic condition, not a single gene, but many genes. And we don't know yet exactly which genes, but it's like high blood pressure, diabetes, multiple genes. But like many illnesses in humans, and probably in animals, it's an interaction. The symptoms arise from your genes and from what happens to you after birth. So if you're born with the genes, you're at risk of getting polycystic ovary syndrome, and you may get it anyway, but you may not have the symptoms of it until you put on weight. As you put on weight, your SHBG, the sponge thing, goes down, and your testosterone works more on your skin and you become symptomatic. So anything that raises the SHBG is your friend, and the contraceptive pill does do that. And obviously losing weight is a marvelous way of raising your SHBG and making you less symptomatic. One of the things that Helen was talking about, we should talk about more, people glibly say lifestyle modification, and that's an easy thing to say and a difficult thing to do. I've had a BMI of 27 for 5 years, and I've been working on it for 5 years and got nowhere. So losing weight is not an easy thing to do. But if you lose weight, then your periods become more regularly. 20 years ago or more, I was doing a research study looking at blood flow in the womb of women with PCOS, and we picked women who were having very few periods. And it was very difficult to finish that study because for some reason they started losing weight and all their periods came back. So weight loss is a very important contributor to the management of PCOS. Most doctors know nothing about it. Many of them don't even know what services are available in the NHS. And there are services, there are local services for people with a BMI between 30 and 34. And you can go to a specialist centre if your BMI is more than 34. So lifestyle modification is important, but I know that it's not easy. But the traditional treatment was the pill. Now, the reason why metformin comes on that list, and many of you will have heard about that, metformin is a diabetes drug and been around for a very long time. I went to medical school in 1975 and it wasn't new then. And it's what's called an insulin sensitizer. Now, insulin is a hormone that puts glucose into cells. So when you have your Krispy Kreme, your blood sugar goes up, and then insulin is produced from your pancreas, and it stuffs the glucose into the cells, so your glucose level drops. So it gets glucose out of your blood. Now, people with PCOS have insulin resistance, and you'll all have heard about that. And what that means is, and it's particularly in skeletal muscle, in muscle. So it means that after you've had your Krispy Kreme, the body produces insulin as it should, but it doesn't work very well. So your glucose stays in your blood and doesn't go into the cells, and you have a relatively higher level of glucose. And people with PCOS have insulin resistance. Now, all of us, as we get heavier, get more insulin resistant. But a woman with, say, a BMI a little bit raised at 27 or 28 has more insulin resistance if she has PCOS than another woman with the same BMI who didn't have PCOS. So it's an unlucky thing to have because it makes you more prone to get diabetes. And I think we're going to see this in the next slide. Is the next slide about metabolic syndrome? Where do we get metabolic syndrome? Oh, we've run out of order. Anyway, there's a thing called metabolic syndrome. When you have a raised level of cholesterol, you have a high level of sugar, you have insulin resistance. And this makes you more likely to get diabetes, type 2 diabetes. And I'm not here in the business of frightening anybody because I'm sure you already know this, but people with PCOS are more likely to get type 2 diabetes than people who are not. And that risk is particularly higher if you're overweight. So we're going to get on to GLP-1 agonists, but obviously what they do, and we hear about them all the time, and they're a tremendous innovation in medicine, is they help people, not just people with PCOS, not just women and men, to lose weight. And what they do, they're called GLP because it stands for glucagon-like peptide. So this is mimicking a natural hormone that has a number of beneficial effects. It puts glucose into cells and it limits your appetite. And these are drugs which are similar in molecular structure to this natural hormone incretin. And they've been around for a number of years. We did some research on it. Oops. And I'll talk about that a bit in a while, but I'll tell you the answer at the beginning. We published what's called a meta-analysis. So we looked at all the different studies of drugs that have been used to help people lose weight with PCOS. And at this time, liguritide, the first GLP-1 agonist, was new, but it was the most effective treatment for women with PCOS to lose weight, and it remains so. So these drugs, and you've heard about Ozempic and all the other ones are all this type of hormone that have been proven to be effective. I'm afraid we've got some dog company here, in people losing weight. Now, this session is about GLP-1 agonists in PCOS. Now, the news on that is there are relatively few studies on using these drugs in PCOS. There are some, but the vast majority of the research has been done on women or men and not people with PCOS. But we know that people with PCOS tend to be overweight, and we know they're insulin resistant. So it's a very logical treatment to use, but we don't have big studies yet of GLP-1 agonists in PCOS. Helen, we've probably gone off-piste with these slides. Have we got to go back to some, or what have we got to do?
Yeah, no, I just wanted to just quickly show the ones that are on the market, because sometimes when we talk about GLP-1s, where people tend to, it's a bit like, calling it a Tampax instead of a tampon. People go with the drug name. So there's semaglutide, which is Ozempic, Wegovy, Rybelsus, liraglutide, which is Victoza, and tirzepatide, which is one of the more recent ones, which is Mounjaro and Zepbound, and then there's exenatide, which is Byetta. So sometimes it's just helpful to just show the drug name with the actual receptor agonist that is on the market. Just there is a difference between each of these. Some of them are actually different molecules: semaglutide, tirzepatide, liraglutide, and exenatide. But I'm going to move to what the results have shown. If you're ready for this part.
Go with that.
Great.
So in general, in overweight people, women or men, they are an very effective treatment for helping people to lose weight. Like most strategies for losing weight, they only work while you're taking them. So there has to be some supervision of it and hopefully some adjustment to your lifestyle, diet, and exercise so that when you stop taking it, you don't gain weight. Now, one thing I think I need to stress here is, and you know this, there isn't, at the moment, even the people, set aside PCOS, even people who are obese and maybe have comorbidities, the NHS doesn't fund by any means treatment for all the patients with those conditions. So even if you just take very overweight or obese people with diabetes, there isn't enough funding for all those people to get these drugs. And the guidelines for prescribing it relate to BMI, and they relate to what we call comorbidities, which are things like diabetes. There is no mention of PCOS in the NHS prescribing guidelines for these drugs, as far as I'm aware. So if you go to your GP and say, I've got PCOS, I'd like one of these drugs, it's very unlikely that your GP is going to prescribe it, with a bit of logic, because at the moment, their efficacy in people with PCOS is less well known than it is in the general population. But as you got on the slide there, these improve your glucose levels. And because they help you lose weight, and for a mixture of reasons, including that sponge thing, the SHBG, your periods get more regular. People with PCOS have inflammation of their blood vessels, which makes them more likely to get stroke and heart disease, and it improves that. And by losing weight, it helps you get pregnant, because losing weight is one of the best things you can do if you have PCOS and you're overweight and you want to get pregnant. So there is a lot of logic in using these drugs, and they are being used, but I think you'll struggle fail actually to get these prescribed solely for PCOS. But many of my patients fit the other criteria for it. They're PCOS, but their BMI is 42. So you will get it, but you won't get it solely for the PCOS. Should we move on to the next slide, please?
Yes, it's just about a GLP-1 and a metformin combined regimen.
Yeah. So there is evidence in PCOS that combining GLP-1 agonists with metformin is more effective than either alone. So these drugs are more effective than metformin. And by the way, metformin has some beneficial effect on weight loss in PCOS. But taking GLP-1 agonist and metformin is better than either alone. Okay. I'm just conscious I'm talking a lot. We won't get to the questions.
That's all right. No, it's good. I think we're on the second last slide here.
The home straight, right? So
we're on the home straight, yeah.
We are, okay. So these are good treatments to lose weight. And one of the other things you might bear in mind in all this is, if for some reason you need IVF to get pregnant. Now, the way in which PCOS affects fertility, by the way, is obviously through infrequent or absent ovulation. So it doesn't block your tubes and it doesn't affect your partner's sperm count, right? So the thing that it does is it may interfere with ovulation. Now, we have very good treatments for helping women ovulate. So this is very treatable, but they work less well in women who are overweight. So the drugs that we might use, there's something called letrozole, and there used to be clomiphene, which are very good at making people with PCOS ovulate, work less well when you're overweight. So NHS guidelines are that your doctor will not give you those drugs if your BMI is over 30. So you're barred from getting NHS fertility treatment if your BMI is 30.0. So this might be a smart thing to do, so you can lose weight, and then you'll then be able to access whatever NHS fertility treatment that you need. And the treatment will work better for you if your BMI is less than 30 than more than 30. And so Helen was saying that when people are at home and during COVID, losing a lot of weight, lots of times when they and their husband were in the house at the same time, there are a lot of these babies being produced. But beware, we don't know. In fact, we have reason to believe that this drug may not be safe if you take it when you're pregnant. So you have to stop taking it 2 months before you try and get pregnant. So you should stop taking it, use barrier contraception before you try to get pregnant. Okay, next slide, Helen, if we move on with that.
Great.
Now, the NHS makes great play of monitoring of this drug. And of course, all drugs are dangerous. And I talk to loads of patients, and certainly more of them are getting their drugs privately than they are from the NHS, because this is just difficult to get on the NHS. But I say to them, is someone looking after you? Because it isn't at all ideal just to go to an online pharmacy in another country and buy this drug. There needs to be some monitoring of it. Most of the side effects are what we call gastrointestinal, so nausea and vomiting. But please just don't get the drug and take it unsupervised. And don't be afraid. Tell your GP you're taking it. They will know that loads of their patients are taking this. So it's really good if your GP knows you're taking it. And what I heard the other day, which I didn't know, apparently, is that at the moment, these drugs are patented. And so the drug companies can charge what they like. And as you know, the price recently went up. It comes off patent, I heard, in the UK, if this is correct, in the next year or so, when other companies will be able to make the drugs and they will sell it much cheaper. So within a year or so, the availability of this drug privately at a much lower price is on the horizon, which I think is a good thing. Can we have the next slide, Helen? Yeah,
That's it. We're finished. We're ready for questions.
Okay.
You've been galloping through, hoping we can get to the questions.
Okay.
But thank you for running through all of that and any information. We wanted to make sure that everyone, because sometimes we can front load and get lots of questions on different aspects, but actually sometimes if we can cover as many of those things through explainers, it makes your life a little bit easier. So what we'll do now is we've got 15 minutes for questions, so we'll get to some of those, or hope to get to some of those. Thank you so much. And in the chat, you are very welcome.
Thank you.
Dr. Hardiman did all the heavy lifting. Somebody's asked if the slides will be sent out. Yes, and the recording will be too. So I'm just going to start here. Somebody said they were recently diagnosed with PCOS 2 months ago and have felt overwhelmed about what to do next. 28, and I'm getting married next year and hoping to try to conceive soon after. What should I be doing now to prepare for that?
Okay, good question. So the first thing is that when people get diagnosed with almost anything these days, but including PCOS, you go onto Google, and you can be confronted by a tornado of bad stuff, and you can walk away from your phone thinking, I'm going to get diabetes, I'm going to get high blood pressure, I'm going to have a stroke, I'll never be able to have children. So the answer to your question is, as I mentioned, PCOS only affects fertility in that it affects ovulation. So if you're having regular periods, there's no reason to believe you're less fertile than a woman who does not have PCOS. So if you're having regular periods, you're probably ovulating. Women with regular periods, 94% of them are ovulating. So if you're having regular periods, you don't need to worry very much. But I can help you worry even a bit less with this information. So about 10 years ago, a study was done in Australia, which looked at a very large number of women, both those with and without PCOS. And they followed them up until the menopause, and they saw how many children they had. And the number of children that women with PCOS, the average number of children that women with PCOS had, was exactly the same as the number of women without PCOS.
Wow.
So you're not, because I say this to patients because often the things that worry us most when we go to the doctor are the things that we can't articulate because we're too scared of the answer. So and I say to women, when you put your head on the pillow at night, just remember what I just said to you, right? You're not going to be a person who's going to have to get a dog and watch Netflix series, right? Your chances of having a baby are as good as other people's, but you may need some help if you're having irregular periods. The only thing that you need to do if you're getting married soon, and whether or not you're having regular periods, is if your BMI is abnormal, that's to say more than 25, then try and lose a bit of weight. But don't stress about it excessively. Like I said, and by the time you get to the menopause, you'll have had as many children as women without. And if you're having regular periods, it's as far as we know an irrelevance that you've got PCOS. And if you're a bit overweight, lose some weight. But there is much more positive news about this condition than people would have you believe. And if you look at Google, you could be very frightened. I don't know whether that answers your question.
Yeah, I think that's good to know. Oftentimes, when you see the words infertility or people being sent, like your patient who disclosed at every bar, I may not be able to have children. It makes me quite sad when people are given pieces of information without actually clarification that no, it won't be. It's not a definitive. It means that some people can take longer to conceive, and it's not that you won't conceive at all. So thank you for that one. We've had everyone's sat up now and they're at their keyboards typing lots of different questions. So there is a question saying, are you in favor of prescribing GLP-1 in women with PCOS that have a normal BMI?
No, I'm not. I know
Considering the
doctors
positive
always.
effect on cyclin and insulin resistance.
Yeah, I mean, doctors tend to be miserable people, always looking on the downside. But there are side effects with this drug. It's also, if whether you buy it or the NHS buys it, it's expensive. This is not a drug. I mean, it may have some theoretical benefit in improving insulin resistance, but this is not a drug that was designed to be used or should be used in people whose BMI is nearly normal. So I strongly wouldn't recommend it. It's natural that you might want to take it. A friend of my son's who's got a BMI of 27 or something said he thought he was going to go and get some of this stuff. This is quite a powerful drug with some side effects. And if your weight is in the normal range, this isn't something that you should be taking. I saw that somebody asked a question, and it's related to the question, the same thing. Somebody said, should I take these drugs if I've got a normal BMI because of insulin resistance? And the answer is no, you shouldn't. I strongly feel you shouldn't. I'm not being miserable or grumpy. I just think it isn't the right thing to do. But somebody mentioned about something called inositol. Now, inositol is something which has been shown to have some benefit in PCOS. It's another what we call insulin sensitizer. It's a molecule that is found naturally occurring in some foods. So it's kind of like a metformin type thing that reduces insulin resistance. And you can buy it. There was a company that makes it. I don't know whether they still do, and they charged a fortune for it. But there's a very, very clever thing that you might have heard of, where a man comes to your door and drops parcels through your door. I think it's called Amazon, and they sell inositol, and you want to take a gram of it a day. It's also very present in grapefruits, right? So if I were somebody with a normal BMI and I was worried about insulin resistance, I might take some inositol. Whether or not that prevents you from getting diabetes in later life, we don't know. People hope that with metformin. So there was a study done a long time ago, 20 years ago, on people with pre-diabetes, not PCOS, but a number of conditions, pre-diabetes, including men. And they were randomized either to lifestyle advice or lifestyle advice plus metformin. And the number of people who went on to develop diabetes in the two groups, in other words, those taking just lifestyle or lifestyle metformin, was the same. So I think I had a patient that came to see me and she was fixated on her insulin resistance, but was not overweight and had no symptoms. And yes, it will be better not to be insulin resistant. I mean, it's not an easy thing to diagnose, actually, insulin resistance. It's not commonly done. So you either have to have a thing called a glucose tolerance test, where the doctor takes your blood test and you then have a drink of sugary stuff and they measure your glucose, or you measure glucose and insulin. I think the best treatment for insulin resistance, if you've got it, and most people don't have it properly diagnosed, would be lifestyle. It would be lifestyle intervention. And I certainly wouldn't take these drugs if just with a normal BMI. I think it's a bad idea.
One of the largest studies that was carried out showed that in women who were anovulatory, so they weren't ovulating, or they had irregular cycles, by changing one of 5 lifestyle interventions, 70% of them regained ovulation. So that was, dietary strategies, losing weight. But I think importantly, linking in, so often we talk about dietary or lifestyle, and it seems so annoying because you're like, pin down what it is I need to do. Give me a checklist. Like dietary and
Mm.
lifestyle seems so generic, and overwhelming, in fact, when actually if you start to look at how somebody has asked, how do we naturally increase our sex hormone binding globulin? If we want this to be mopping up that testosterone, how do we naturally increase it? But and a similar strategy to naturally increase your sex hormone binding globulin and naturally reduce insulin resistance is starting with making sure that the food that you eat has a lower glycemic load. So, you know, you're taking out your refined carbs and going for whole grains, making sure you're eating as many vegetables and fruits, but also then increasing your dietary fiber. The more and more we learn about our gut microbiome and the role of increased dietary fiber and having soluble fiber, whether it's oats and beans and flax seeds, it really does help with glucose control, but also naturally increasing your sex hormone binding globulin, and then getting like balanced protein as well. And it seems I think when you can attach a logic to something like that, then it's much more, it's more of a digestible lifestyle tip. So like I will, this is ridiculous, but I make my daughter for breakfast, to make it sound nicer, I will say, you can have the 3-bean queen. And I 3-bean queen came out of the fact that she asked me to open a tin of something and then asked me to open a tin of something else. It was a tin of lentils, a tin of white beans, butter beans, and a tin of corn, just baby corn. And I put the 3 of them in a thing, put plenty of butter in, probably shouldn't have, but it made it tasty. And all I could think was, I just relabeled that. And I was eating it afterwards by the spoonful thinking, it's all right. But if it was medicine, it would be worse, right? So if I had to take medicine that tasted disgusting, you'd do it, right? And I considered eating that as almost like a medicine. I was like, actually, this is so good for me. And why not include it? Even if I don't love it, if I know that it's actually going to, you know, increase my dietary fiber and give me some like nice protein, then why not include that? Even if it was something you didn't love, that you said once a week, I'm going to do a 3-bean queen and I'm going to have that to make sure I'm getting plenty of fiber in my diet. And I think little tips like that can actually really, and like, I'm not fancy here, I didn't boil up any lentils or do anything like that. I took them from a tin, baby steps. But again, I think trying to get in just healthier ways of getting in lean proteins through those soy and legumes or whatever it is, that they slow your glucose absorption and they improve your satiety. You're going to feel quite full after it, especially if you're shoveling in spoons because you didn't want to waste 3 tins of food. But I think that there's little ways that we can look at the literature and look at the simple dietary modifications that we can make to increase our fiber, reduce the number of, reduce our like the non-good carbohydrates that we're getting, and lower glycemic ones like brown bread, brown rice, brown everything. I think that's little things that we can start to do to say, actually, these are ways that, yeah, I'm doing a dietary intervention, but actually it's going to have a direct impact on my satiety, my fiber, my gut microbiome, and over time reduce my insulin resistance and increase my sex hormone binding globulin. So it's a win all around.
Yeah, I think you're quite right. I mean, lifestyle intervention sounds boring. It sounds difficult. But there are some easy wins. You may be a very healthy group of people listen to this anyway, but many of the patients that come to see me are really quite overweight and they're daunted. They've tried multiple diets, they've lost weight and they put on weight again. So lifestyle modification is really about making a small change and sticking with it. 30 years ago, I went on a cabbage soup diet and I lost about 10 pounds in 2 weeks. But of course, I put it straight back on again and it was hell to take that diet, right? So almost all of us now have mobile phones and or fitness watches. So the first simple thing I say to people, and it's surprising how many people in modern life don't do this, is to increase the number. First of all, count how many steps a day they're taking, right? Now, it used to be said you had to take 10,000, but actually, you know, even 7,000 has been shown to be a benefit. So it just means maybe getting off the bus one stop earlier, getting off the tube one stop earlier. Just make certain that you take at least 7,000 steps every day. Simple thing, but it's amazing. And when I look at my step count, on good days, I'm doing 12,000. There's some days I hardly get off the sofa. I've only taken 2,500 steps. So things like that are simple, and if continued, are good, and you'll improve your insulin resistance, in insulin sensitivity in that way. So, like, and the other thing to say, which is kind of interesting, is that people with PCOS and these symptoms that Helen mentioned of anxiety and depression, particularly anxiety, women with PCOS can get something called reactive hypoglycemia. Hypo means less, and glycine means sugar. So in people with PCOS, we did a study on this when they had glucose monitors, that if you have your meal, whatever it is you might have, or your Krispy Kreme, and your glucose soars, as you'd expect, all that sugar going into your bloodstream, but 2 hours later, the blood sugar goes below the normal level. And that's when you feel very tired and what's called tense tiredness. So you feel tired but anxious at the same time. And these are symptoms of reactive hypoglycemia. And they happen when you have these bad sugars, what Helen referred, these are sugars with high glycemic index. So they're sugars, they're sugars that let all the calories out in a quick burst rather than gradually. And some people notice that they have these symptoms of in the afternoon of feeling very tired and lacking in energy, but also very anxious and tense. And this is reactive hypoglycemia because of this sugar rush. And the alternative is to use sugar, to take carbohydrates with low glycemic index, and that might be better. So that's another way in which you can improve your psychological symptoms by a lifestyle by a lifestyle change, by substituting Krispy Kremes for less sugar rush stuff. Okay, Helen.
Okay. Let's talk about how long people need to stay on them. Unfortunately, with drugs like this that come on the market that become this almost like wonder drug, and we honestly are seeing a lot of really positive effects of this, like lowered inflammation, a lot of lowered symptoms. What I think the big fear is, how long do I have to stay on this? Do I have to stay on it forever? Is there a risk that when I come off it, I'm going to just gain all the weight again? I think there's evidence from both camps, isn't there?
Yeah, there is. I think that my understanding, and from what I've seen, almost every intervention that is used to lose weight, diets will be the classic one, but even bariatric surgery, people lose a lot of weight for about 2 years and put some back on. And so it will be probably with these drugs. The answer is that we're still learning about this. The best thing, the ideal thing would be to take these drugs, get your weight down to, let's say, a BMI of less than 30. Let's not be perfectionist. And meanwhile, build up your lifestyle changes so that you don't put the weight back on again. And that's a crucial part. If you go to, I work very closely and have done for 20 years with a specialist weight management service at University College Hospital London. And they don't just make you lose weight. Their aim is for you to lose weight and then keep the weight off, because it is pointless to lose weight. So, and this is the danger with getting drugs from an online pharmacy. There may not be that bit built in about simultaneously lifestyle modification, dealing with hunger cravings and stuff like this. So I think the best, so I don't at the moment think that I would recommend women with PCOS take these drugs forever. I think you take them, you lose the weight, you might then go down to a smaller dose. Meanwhile, you're improving your lifestyle so that you don't put the weight back on again. But that it actually equally applies to people without PCOS. But I suspect we're going to be left with a lot of people who end up taking these drugs for a long period of time, albeit in a reduced dose.
Yeah, I think that's the really important part, is that actually anything like this, you cannot rely on the drug alone. You have to lean into the lifestyle modifications and hope that so that the decreased appetite, and there's actually a lot of links to decreased addiction, drinking, any drug use. There's a lot of really positive signals that it helps with that, but also it's not going to be in isolation. Just taking the drug on its own, I think it's really important that if you just rely on the drug and don't alter anything about your life, then you're going to revert back to the same difficulties that you experienced before. It is 9 o'clock on the button. I think we have time for maybe one or two more questions, because there are so many here. What I would really love to do is just do a bit of a quick fire round on some of them, and then maybe we can have a follow-up where we are really, somebody's asked about, like, how do we talk about this when the evidence isn't there. That's why we wanted to do a webinar, is because I think a lot of companies are jumping on the bandwagon and selling it to people in the absence of long-term evidence, in the absence of waiting it out to see what has happened, and certainly in the absence of presenting any of the data. We are very much information, data, and science-led at Hertilities, which is why before ever offering this service, even though we have a prescription service, we wanted to actually just say, let's get on, let's talk about it. Let's say for the huge number of people who come to us with Hertility, or with at Hertility with PCOS, and for the huge number of people that we helped get a diagnosis, we want to just walk you through what it all means. I think there's still a stigma attached to taking it, right, when people call it weight loss jabs. But actually, this is a medication no different to what is typically being prescribed. And when we're starved of medications and treatments, especially within PCOS that address some of the most common features of it, this is why we want to be able to get as much information. So we're going to be hosting as many of these as possible and refreshing as and when the information comes out. Especially as we start to offer this service to our customers and patients. So the last question I will take is, this is really hard.
And the winner is?
Yeah, exactly. God, I can't. There's too many, guys. You're all throwing them in. I'm going to try and. I can't do it. Hair loss and fatigue are one of my many symptoms of PCOS, which are also side effects of the GLP-1s. What supplements would you recommend to help with these side effects if you're not taking or you are taking the drug?
Okay. So of the symptoms that PCOS can cause, of the classical symptoms, the irregular periods are the easiest thing to take. So the reality is, as a doctor, that if somebody comes to you with a symptom, the doctor usually knows how likely it is their treatment's going to work. So if Helen comes to me with a headache and I give her 2 paracetamol, there's a 90% chance the headache will get better. And we know that, really. But and in PCOS, if you have irregular periods, we can make those regular. They may not be your periods, but you can have a bleed every month. When you get to these symptoms of increased hair or facial or body hair or scalp hair loss, these are much more difficult to treat. And I'm going to tell you a secret, which people, well, a secret, but a wisdom from my, whatever it is, 40 years of this stuff. There are drugs that we can use that block male hormone. One is called spironolactone, which is a drug which was invented to treat kidney problems, but blocks male hormone. And there are others. And it is true that testosterone increases hair growth in women and men on the face and body, and it's a cause of why my hair's fallen out from the top of my head. Incidentally, I didn't know the hair had fallen out the top of my head because I only see the front until my son, when he was young, took a picture of the top of my head with his phone, and he said, "Why is it all pink, Daddy?" And so I then knew that I was bald. Now, these drugs, in my experience, I've been prescribed them since 1987. These drugs, which block testosterone, have very modest effect on increased hair growth or scalp hair loss, such that I don't even prescribe. I can't think, and I've been treating such patients, as I say, since 1986. I can't think of a patient that I've treated with those things that has said, yes, it's a lot better. So I think the drug treatment of increased facial hair and body hair is, in my experience, and there's a lot of it, is very, the response is very poor. And equally, people who are experiencing scalp hair loss, so they're either people whose hair looks thin, or they're people who have what seems to be a lot of hair, but they say every time I brush my hair, loads and loads of hair comes out. I don't believe that these drugs, which block male hormone, have much effect at all. Now, then people say, well, I'm losing hair because of deficiency of some supplements or some, trace elements. So you can measure iron and you can measure selenium and other things. Now,
Which we
I'm on
will
the
be doing
tube.
soon, by the way, just to flag that we will be doing all of these deficiency tests very soon so that we can start to measure, because I think a lack of vitamin D is really associated with PCOS. So
Yeah, there is some evidence of that. But I those who travel on the tube see a clinic, I won't name it, where they show a picture of a person with very thin hair, another person, and there's a man usually, and then loads and loads of hair, and they say, we got this man better. Now, I don't know what supplements they're using. I don't want to depress you, but treating scalp hair loss in women with PCOS, the reason why it's high on Helen's list of Hertility is because doctors either don't know what to do or they've tried things and they haven't worked. So certainly an underactive thyroid can cause scalp hair loss, and iron deficiency can cause scalp hair loss, and maybe some trace elements can as well. But this is, you'll be sitting there thinking, oh, he's such a gloomy person. By all means, maybe go to a dermatologist, go to a trichologist. The medicines that I have seen used for scalp hair loss, I wouldn't say have worked. There is a treatment for excess hair, and it works extremely well, and it's called laser. And sadly, at the Royal Free, we used to have the London Regional Centre for skin laser treatment. And I have barely seen a woman who didn't get a dramatic improvement from, let's say, excess facial hair or body hair with laser treatment. But 7 or 8 years ago, the NHS stopped funding it. And it's such a shame because
they just stopped funding laser.
They stopped funding laser for excess hair growth, a long time ago. And it's a shame because the consultant that then ran it published a paper, actually, where he measured quality of life, so how good people felt about their health day to day. And well, you can also score how much facial hair somebody's got with the Ferriman and Galway score. It's a measurement of it. And his treatment not only made the person clearly less hairy, the woman, it also improved their wellness. So I think it is a great shame that the NHS stopped funding laser treatment. It is the best treatment, for sure. And they're all free. I have to word that, but they still offer it as a patient-funded service. And, you know, I have seen excellent results. I remember one patient came to me, and I've seen a lot of people with a lot of hairy problems. She had hair over her whole body, over her legs, her tummy, everywhere. She was so embarrassed about it, she'd never shown her legs to anyone in the world except her mum. She was 18 by this time. Even her dad hadn't seen her legs ever. When she was at school, she used to get changed, used to hide in the cubicle and get changed and come out with the tracksuit trousers on. And she had whole body laser under the NHS at the Royal Free, and she was a changed person psychologically. And I think it is tragic that the NHS doesn't pay for it. And, you know, there will be a cost to the country of not treating it in terms of days lost off work, you know, depression and anxiety. But if you want, you know, the truth, as I see it, if you have got unwanted hair somewhere on your body, laser is by far the most effective. Now, it does come back. The NHS used to offer 6 treatments at monthly intervals, by which time all the hair had gone. And people needed a top-up treatment, maybe one treatment once a year. But, you know, that by a country mile is the best treatment for excess hair. And the drugs that I've used, I don't even prescribe them anymore because I just don't think they work very well. And I know that's very hard because many of you would want laser treatment and can't afford it. I believe the Royal Free is cheaper than some private clinics and certainly gets good results. But in answer to your question, I think your question was about scalp hair loss. I don't think a gynecologist or an endocrinologist has much to offer unless your thyroid is underactive or you're iron deficient, or maybe if you have deficiency in some of these trace elements. So they're worth checking for, and Helen says that Hertility is going to be offering that. But it is a difficult condition to treat. And I think that's why it's high up on Hertility's list, because the other doctors that people had seen before have tried treatments that hadn't worked.
Yeah, absolutely. Okay, we've gone 10 minutes over, and I'm so grateful for you giving me your evening. I'm so grateful for everyone who's here, that is still here with us at 9:10. We will do a series, and as the evidence comes out, as more data comes out, we're hoping to just disseminate any data that we get on this. We'll probably run a study, so if anyone is taking them, please email researchtrials@hertilityhealth.com and let us know, so that we can include you in any trial that helps give more information to anyone else. Like, so many of these questions haven't yet been answered because we don't have any long-term data, and that is something that we are really, really dedicated to doing, is providing the long-term data that doesn't actually exist. Dr. Hardiman, it is a dream to speak with you and just to learn from you. I'm always grateful for your time and your teaching. And to everyone who joined us, thank you so much. We will be emailing out the webinar to anyone who registered, and please send any email to researchtrials@Hertility Health. If you haven't gotten a diagnosis, you're struggling to get a diagnosis, please do the Hertility test. We are just so dedicated to getting to a diagnosis, to additional tests should you need them, and support. And as always, I am your host. I am going to say good night and thank you to everyone who joined us. Thank you.
Helen, can I just say one thing? And that is that in this discussion, I hope it comes across that I'm passionately sympathetic with women who suffer from this problem. But in talking about it, I didn't intend to cause distress, and I hope I haven't caused distress. But if I have caused you distress, then you need to go and see your GP about it. Because I know this matters a lot to you, and I wouldn't want any of you to be more distressed than you were before you started listening.
I don't think you were in any way. I hope most people are just grateful for this. There is a few comments about compassion. So I think you've been hugely compassionate, and somebody said no distress, definitely helpful, very grateful. I feel better. So that's good news.
And there are treatments for lots of these things,
yeah,
including having a baby.
Yeah, exactly. All right. Thank you so much. And
thanks so
take care,
much, everyone. Have a good evening. Bye now.
Bye.
Bye. If I get rid of that.